Good evening, everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctors for today's panel discussion on Cesarean section. Are we cutting too deep into maternal health? With much pleasure and honor, let me welcome today's host, Dr. Jyoti Malik. Welcome, ma'am. Ma'am is the medical superintendent at JJ Institute of Medical Science, Bahadurgarh, chairperson of ISAR, Haryana. Now, without any further delay, I would like to welcome ma'am again at our forum and would like to hand over the session to her. Over to you, ma'am.
Yeah, thank you so much, Rion, and thank you, IJCP. Since this is an International Cesarean Awareness Week, a month actually, and that is why we are again last week also I spoke on the cesarean section, the steps, the incidents of how we can reduce our cesarean section rate. Today we have a wonderful panel and we would be talking on cesarean section. Are we cutting too deep into maternal health? So for that we have a panel consisting of three experts. We have Dr. Bharti Kalra from Karnal. She is a consultant at Bharti Hospital, Karnal. Welcome, Dr. Bharti, a very renowned gynecologist at Karnal and very experienced person in field of obstetrics. And I'm sure we are going to have a wonderful time discussing about cesareans and how to prevent and how to lower the cesarean rates in India. And then we have our second panelist, none other than Dr. Savita Singhal. Dr. Savita Singhal is a very, very renowned obstetrician and gynecologist. She is professor of Obs Gynae department at PGIMS Rohtak. So the premier institute where we get so many obstetric cases, not only and it is a referral center. It is one of the biggest referral centers of Haryana, and I'm sure we have so many cesareans happening there. And how do we still keep the rates low? We would learn from Dr. Savita. And then we have the third panelist, a very young and dynamic obstetrician, Dr. Neetu Balyan. She is an associate consultant obstetrician and gynecologist at JJ Institute of Medical Sciences, Bahadurgarh, and she has done her post graduation from Chandigarh, the institute where she has gained a lot of experience dealing with high risk cases and doing a lot of high risk obstetrics. So, welcome to the panelists. And since we are talking about how to reduce the cesareans, because this being the awareness month, the cesarean rates have really, really gone up. And I don't know who to blame, whether it is the obstetrician to be blamed or the patient to be blamed, or we are under pressure, we are being guarded by the medico legal, we are scared of those medico legal workups that happen in these days. So let's dissect what, where, how do we start, why, and how to control this being reducing the maternal mortality, morbidity, and the neonatal morbidity mortality, and also keeping the cesarean rate very low. So this is our motto actually, and right from 2016 to 2021, the cesareans that were 17% have gone up to 21%. And it is a lot of variation state wise. I mean, I was surprised to find out Telangana has 60% cesarean rates, whereas Nagaland has 5%. So how much difference across the country we have, and on an average, I mean the cesarean even worldwide, it is not only India. US, 1 out of 3 ladies delivering is by cesarean. So I think we start with the youngest, our team player, Dr. Neetu. And my question today for you is a very simple explanation. What are the indications of cesarean for everybody? since we have a lot of people joining, not only obstetrician gynecologists from other groups also. So, what are the, in briefly, what are the indications?
Yeah. Thank you, ma'am, and good evening, ma'am. Good evening, Savita, ma'am. Good evening, Bharti, ma'am. This is a very nice question because keeping in mind that today's cesarean rate that vary in India between 60 to 5.2%, as ma'am told, average life rise rate from 2016 to 21 from 17 to 21%, and we can't tell what are the major indications. The rising trend is toward the on-demand cesarean, which patient demand, primary indications. So decrease this, WHO has made a target to decrease the cesarean rate by 2030 to 23.4%. For this, Robson criteria will help us. Robson criteria include 10 classes of cesarean, and every obstetrician, before planning a cesarean, should classify her cesarean according to Robson classes, in which class 1 and 2 include singleton vertex nulliparous cesarean, that patient are more than 37 weeks. Class 1 include with the patient who is in spontaneous labor. Class 2, the patient in when had performed the induction of labor. Class 3 and 4 include multivariate singleton vertex cesarean that are more than 37 weeks. 3 include patients who are in spontaneous labor. 4, in whom we have performed the induction or patient went into cesarean before patient goes into active labor. Class 4 cesarean include patient who had a previous one cesarean. Class 5 include patient who had previous more than two cesarean. Class 6 include all primary nulliparous cesareans, and class 7 include multiparous breech for perform for the breech. And class 8 include all cesareans which are performed for multifetal pregnancy. Class 9 include class cesarean which are performed from transverse or oblique line despite of parity. Class 10 cesarean include singleton vertex cesarean who are performed in preterm patient less than 37 weeks of gestations.
Yeah, so that is a wonderful way of expressing the indications. So we have the Robson's criteria, and these days there are current recommendations also in improving the quality care and the role in reducing the NSTD cesarean rates, that is the nulliparous singleton term vertex cesarean rate. So that is actually a lot of patients that we get in our OPDs are previous cesareans, and if we reduce the first, I mean, if we somehow do the first cesarean with a lot of thought behind it, with a lot of proper indications, obviously our cesarean rates will go down. Now, you said about the maternal request.
Yeah,
So, Dr. Bharti, I mean, how can we objectively balance a maternal request versus a medical necessity in the cesarean section decisions? You might be getting a lot of patients where they say they do not, the young girls these days are very scared, and they say, no, we want a cesarean delivery. We don't want a trial of labor. So, how do you balance in your private practice regarding this sort of a situation that you encounter, and how do you counsel these cases?
First of all, I thank IGCP and this group, those who have taken up this initiative. Because in day-to-day practice, we see so many patients asking for cesarean. So in those patients, we have to give them extra time, and we have to look for what is their concern. What is their concern is biomedical, psychological, or social. So these are the three paramount aspects. Plus, the fourth aspect is of environmental. If she is concerned about her own health, sometimes with the vaginal delivery they are fearful about the pelvic floor defect or pelvic floor laxity, urinary incontinence, what they have seen in their senior generations. Means if they have seen in their grandmother or mother suffering from complications after vaginal delivery, so they are scared of that, or in their neighborhood, means vicarious fears are there. So in those cases, we have to see whether they have biomedical fear about herself, her unborn child, or about her future sexual health, or any kind of concern she is having, because that is a very common concern. the husband says that we don't want a vaginal delivery because of these pelvic floor complications, or she has some psychological component. Psychological fear is there in her mind, that I will not be able to tolerate the uterine contractions, the pain. The fear of pain is there. That is known as tocophobia. So that we have to control. We can give them psychological support. We can give them the doula care. Means their attendants can be kept in the room. In our hospital, we keep patient throughout labor in the room with their attendants. So we have to counsel them that that is not a fear. In case you fear some kind of labor pains or you are unable to tolerate, then we have options of analgesics in the form of injectables, as well as in the form of labor analgesia, that is the epidural analgesia. So we need a set of counseling. Or if they have some social fear, like the husband is coming from out of station and he is getting just a 1 day 1 week leave, so in those cases, we have to tell them that they want on the first day of their his vacation, they want the cesarean to be done. So we have to first scrutinize about their actual concern. Or sometimes they have obstetric astrology. Their astrologer has told that this is the auspicious time. You have to get delivery done at that time. So we have to segregate the non-medical indications, means the indications for CDMR, and we have to answer it accordingly. And if we find it genuine, means if we find that if we induce the particular patient and the labor is going to be a prolonged labor, and in those cases, patient may land up in complications or the labor fatigue, that kind of problem may arise. In those cases, we can consider her request, but not otherwise. For all the social reasons, we don't want to consider her request.
Right. So very nice, but I think it needs a lot of counseling. I think
Yes.
that is the basic thing, that we have to tell them that I mean, these all sort of phobias that you've spoken about, we can take care of them. We can take care of the pain. We have good epidural analgesia these days. Then the birth attendant, we always during antenatal care also we talk to them. Who's going to be with you? I mean, they have to sort of whoever they feel comfortable. They may be comfortable with their mother-in-law, their sister-in-law, husband, whoever. So, I mean, that person can sort of be during labor, can pacify her, can do some maybe, can be do some massage or some whatever relief, however they can they can motivate her to get through those labor pains. So that is something that needs to be done by each obstetrician, and it needs a lot of time during our counseling time as well. But
Very good
no
evening to
doubt.
all.
Hi, good
Can I
evening,
get?
Dr. Savita. Yes, we need
Yeah,
your comments as well. Yes.
so I think it is very, very essential to spend time, like Dr. Bharti has told nicely, that whatever her fear is, that is to be taken care. Along with that, we have to, in addition to this, we have to tell the disadvantages cesarean also. Means if you go for the cesarean, because sometimes patients feel that there is no disadvantage. They just think it is as good as the normal generally, even better. Some are having this conception in their mind the cesarean is better than a general delivery. So along with that, relieving their fears, psychological things, we have to highlight what are the disadvantages of cesarean over the vaginal delivery. So that may even more help them in coming towards the vaginal delivery.
Very rightly said by Dr. Savita. And here I would rope in Dr. Neetu and I would find out what are the risks versus benefits of cesarean on demand. So we have to tell them what are these are the risks, these are the benefits that Dr. Savita just mentioned. So can you
Yes.
elaborate on those, Dr. Neetu?
Yes, yes, ma'am. Yes, ma'am. As Bharti ma'am told ma'am, before making the decision for cesarean section for a patient who is demanding cesarean, we should first of all ask the concern of patient why she is asking for a cesarean. We should make a birth preference and in antenatal period, and also explain the patient about the, as Savita ma'am told, about the risk of repeat cesarean, risk of abnormal placentation, need for hysterectomy, need for adhesion, need, and risk of chronic pelvic pain, decreased fertility, need, risk of further spontaneous abortion, ectopic pregnancy, so that patient can be understand, and we can also explain the risk of neonatal resuscitation, increased risk of transient tachypnea of newborn, respiratory difficulty in newborn, and more hospital stay, more NICU admission to the patient.
So, are there any benefits? You've spoken about the risks. Is there
Yeah,
any benefit that we can tell them that then they have to decide? We have told them so many risks. So, any
Ma-
other benefit of a cesarean, of a elective cesarean?
Ma'am, some of the benefit, only one benefit is there is a reduced risk of postpartum hemorrhage who went for elective cesarean than a patient who is gone for cesarean who was in labor. And there is a decrease in hospital stay and sepsis rate. Otherwise, no more benefit.
Urinary incontinence or the fecal, that the side effects of a
Uh,
vaginal delivery
no, ma'am.
are
No, ma'am. Till
no.
now, no data have suggested there is any change between the vaginal birth and cesarean who was performed electively.
Immediately, maybe after delivery, maybe they might have a little bit of urinary incontinence, but at the end of 2 years, when it was compared between a vaginal delivery and a cesarean, there was no difference. So
Yes, ma'am.
anyhow, that means there is no advantage of elective
Yeah.
cesarean on demand. So that is very, I think we are all standing on the same platform and talking the same thing, that we should not be provocating or advocating or supporting this, and we should take time and at least talk to our patient about all this. And is there any particular clinical scenario that you would prioritize a maternal choice over clinical guidelines in deciding the mode of delivery, Dr. Bharti? If there's any particular indication that we can think of.
For this, I just want to give an example of one of my patient. The patient from a village she came. She had earlier she had birth asphyxia in her previous child, and that child had to suffer for 2 long years, and ultimately that baby passed away. So she had so much of mental trauma because of that childbirth, and she had fear of labor and vaginal delivery because she was scared that if I get labor again, my child might be again get birth defects. So she was very clear in that I want to go for cesarean. So if someone has traumatic past experience of labor pains, and I just remember one of my patient who had prolonged labor, and in next pregnancy she brought her mother-in-law, and both of them asked me to give consent for cesarean at just 7 weeks of pregnancy. At start of pregnancy, at her first visit, we had taken the written consent when she had asked her mother-in-law and husband to give consent that they will get her cesarean done. So that is the impact of bad past experience. Even if they have it or in their family members, if someone has got that kind of experience, in those cases we take that thing takes priority. In those cases we go for CDMR, but because that patient has very severe phobia of labor pains, that I can't take it. Or even if in those patients, those who had tried for vaginal delivery and at full dilatation, they landed up in cesarean. So they also have traumatic bad experience. So those cases, their choice takes priority over their medical indications. Even though
Right.
we counsel them to will take full care in case any problem arises, we will go for cesarean, but such circumstances take precedence.
Yeah, I'm sure everybody has such a one or two patients who are really who need. I mean, even we are scared in trying to give a vaginal delivery to them. Suppose if they had birth asphyxia or they had a mentally retarded child just because of application of forceps or a vacuum. Dr. Savita, in your
Especially
government
if it is a
hospital,
high risk pregnancy, then
yes.
also we can go with this. Like if it is a IVF baby is there, she's married for so many years, and then also we can think of doing the cesarean section. High risk
In your
pregnancies.
yes, so very high risk pregnancies also is another indication, then bad obstetric experiences, as Dr. Bharti stated. And in your practice, Dr. Savita, do you also get such sort of request in your government setup, or the patients in your they don't ask for such sort of they don't have such demands,
Yeah,
the
nowadays
patients
it
that
is
come
almost
to
negligible.
government
Yeah,
hospital.
I think about 5-10 years back we were getting some patients for the getting the cesarean on demand, but now it is almost negligible. Patients are not coming to our institute with demand, especially like high risk pregnancy patients. Sometimes they say they prefer that if you go for the cesarean section. In that case, we also have the opinion that yes, this patient should have the cesarean. Otherwise, in our hospital, in government institute, they're usually not coming on the demand, cesarean on demand. They're not
Yeah.
requesting it, most of the patients. I think they know
So
that this
how
message
do
is there with them
that,
that we will not be doing. So that's why that may be the change in the scenario in last 5-10 years. We're not getting the demand for
right?
cesarean.
And again, to you, Lee, the next question that I would put is, how do you think a rising cesarean rate is affecting the maternal morbidity and the mental health or the postpartum recovery compared to a vaginal birth? Their morbidities, their mental health, and the postpartum recovery between
If
a
it is
cesarean
affecting
and a,
actually, morbidity is definitely very high in case of patient with cesarean, especially if it is previous cesarean section. But Neetu has already explained few things. There are more chances of sepsis, hospital stay is more, and then UTI chances are again more because we are always catheterizing the patient for cesarean section. Then we shouldn't forget about the anesthetic complications. Like anesthetic complications are
yeah,
so
absolutely.
high in case of cesarean section. And PPH is more because always bleeding is always more in a cesarean section as compared to the vaginal delivery. So these are the morbidity which is there with the cesarean. If it is a previous cesarean, then long-term complications can be there with previous cesarean. If she next time she conceives, there are chances of placenta previa. We all know there are chances of preterm labor. There are chances of past placenta accreta also that is also increased. More chances of abortions and more chances of repeat cesarean that we already know. Because as this Robson criteria are there, basically this classification is for the auditing of the cesarean section. How we can audit, how can decrease the previous repeat cesarean section. Actually, class 1, 2, 3, and class 6. These are the classes in which we can have a control on the rate of the cesarean. Few classes with previous cesarean, we're not much worried that we can go for the repeat cesarean in that. So that is for the auditing purpose. So this is the fear in this, and even in the postpartum. But especially for initial 24 hours, patient may not be able to handle her baby as she is able to handle in case of vaginal delivery. So it takes little time. Though we say the breastfeeding should be started immediately here, but she needs help till the time she's in the hospital. She's not able to handle the baby. So this psychological trauma is there in the cesarean section. Even for social aspect, because she may not be able to see so many family members. This is always we say that less number of people should be there to avoid the infection. So these psychological problems are there after cesarean more as compared to the vaginal delivery. And even it has
Right,
been seen that postpartum depression, though it is common in both, can be there, but it is little more after the cesarean section. And then
right.
long-term complications can be there. If she's not conceiving, then also there are chances isthmosil. If patient develops isthmosil, there are chances of this AUB, abnormal uterine bleeding, or she can have scar endometriosis. We are seeing the patient suffering from scar endometriosis or after cesarean section. So that is also a complication which is more common with the cesarean. Though we can have these endometriosis in vaginal deliveries as well, but that incidence is a little less as compared to cesarean section.
Yeah, so these are certain things that with the increasing cesarean, scar endometriosis, isthmoseals, and scar ectopic. This is something new that more and more scar ectopic patients are being diagnosed and coming up with the increase in number of cesareans that we are doing. So, do you routinely counsel, Dr. Bharti, your patients about the potential risks that can happen during cesarean adhesion, the effect on fertility, and the scar dehiscence, etc., that can when they are coming to you during antenatal care? Do you talk to them about these all the problems that that can happen in case of a person who is a primee, who's where we are not even, I mean, when so that she can get mentally prepared that she should be going for a vaginal delivery. And if she is a previous cesarean, how do you talk to her? What how do you mentally prepare her so that she is whether willing for a TOLEC?
Uh, for the primary patients, in all antenatal visits, we encourage her to go for vaginal delivery. So that is the encouragement. We tell them to take nutritious diet and the exercise they should continue. For that, we enroll them to the programs in which the antenatal exercises and all kind of nutritional activities, yoga, meditation, all these things are told. So till the time in our practice, till the time we need to do go for cesarean, till the time we encourage them, you will do well, you will go for vaginal delivery. In case we are unable to do it, then you will need cesarean. And especially for those who are asking for cesarean, sometimes patient in their first visit, doctor, I am pregnant, I want to go for cesarean at my time, please don't come under pressure of my family members, I will go for cesarean. So in those cases, because in private practice we find so much of that demanding patients, so in those patients we tell them that we have made a mnemonic of black, BLACK, that is the B is benefit of cesarean that we have already discussed. Limitations of cesarean. Whatever their concerns, we will be able to answer those with the cesarean or not. And A is adverse effects. So we tell them about the adverse effects. If you go for vaginal delivery, you will get the sense of satisfaction, as we do. Because as obstetrician, if we do vaginal delivery, we get the sense of satisfaction giving the healthy mother and healthy baby vaginal delivery through vaginal delivery. That is for us. So similarly, you will also get the endorphin levels will increase. You will get the benefit. And if you go for cesarean, you will get all the you are at risk of getting these side effects, which what Dr. Jyoti has already told. So adverse effects, and C is the cost. Definitely, cost is more. Although we charge almost same for the efforts taken for the vaginal delivery as well as for the cesarean, but overall cost will increase, and we impart them the knowledge about, because in our OPD we have put the posters, and in with our OPD slips we give them the leaflet about the information. So that information is imparted, and at the time of delivery, means in the third trimester when patient comes, although we encourage them about, we have given the chart about all these exercises and when to come, how to come, all these things are mentioned, but along with that we get the consent that we will try for vaginal delivery. In case that doesn't happen, we may need to use forceps and vacuum instrumental delivery. If that is not possible and we are unable to do it, we will go for cesarean. So for the consent purposes, we take all these consents and we ask them whether you are okay while going through all this. This is our routine sequence of going through. And if you deny or if you don't give consent for any of these, then we will think otherwise. Means if patient says even if she delivers vaginally normally without any instrumentation, then it's fine. But if she needs instrumentation, we will not like to go for instrumentation, we will like to go for cesarean directly. So that kind of consent is already taken with them, and that is refreshed at the time of need. Means just if we find that she definitely needs instrumental delivery, then we take consent again just 5 to 10 minutes before applying the instrument.
Yeah,
So
that
that's
is a very important the way you have explained. I mean, the patient understands that we are trying our best for her to deliver normally, vaginally, and if needed, she may need a instrumental delivery. But if it fails, then obviously, definitely a cesarean is the only way out. But at least the patient understands that okay, these are the things that may happen. But sometimes what the patients these days, they feel that doctor is not trying to do a normal delivery and they are wanting to make money, and that is why they are straight away telling us to go for a cesarean. So I mean, that faith is and the trust is, there is a breach somewhere. And how do we bring back that trust in the patients? I want to ask everybody, I want to take everybody's comments, how we can bring back the face of a doctor that was there 30 years back, and that we are not, now we don't have that. What can we do? Though, see, Dr. Bharti has explained everything. We do this, we give them exercise, we talk to them, but still at the end, the relatives feel that it was intended to be a cesarean only. And because obviously delivery, you are sitting with the patient for 8-10 hours, and at the end of it, still not sure whether it will culminate into a normal delivery or it would land up into a cesarean. So how do we talk to the patient, and how do we built it. It is the joint, I think, discussion that we need to do here.
Actually, the continuous counseling of the patient. If patient is admitted for the normal labor, so before labor you have counseled that she is for the normal delivery. And during the process, if you tell something about that this is the normal process, these much hours may be taken till this dilatation, and if anything happens at the time of if some emergency is there, so if you explain well to the patient that this has happened, and because nowadays we're having all the records, we're keeping the CTGs are with us, fetal heart sound dips, then we can well explain, we can tell the dilatation is not proper. I think then faith will be there. It is not that they are not coming with this. And naturally, if you are keeping the patient for the normal vaginal delivery, then they know that they are keeping for vaginal delivery, they're not doing for, but especially doing the elective cesarean section. Then also Dr. Bharti and everybody has explained so nicely that it's very good idea Dr. Bharti has told to give the leaflet that this is that, so it is better to go for the vaginal delivery. And I think there will be no problem with the trust. And basically, I want to say that the this is cesarean section rate is increasing day by day, and it was quite less few years back. But some of the factors are unavoidable. I will say it is not dependent on the doctor or the patient, because some new things has arisen in last 20 years, increasing age of the marriage. Previously, the marriage was at the earlier age, less than 30, they were able to produce two children, three children. But now the people are being, the girls are being getting married 30, 35s. And we already know that if elderly primary gravida is there, already she is having complicated pregnancy. There are more chances of cesarean than the normal delivery. Secondly, last 4 or 5 years after COVID, I am just observing that the rate of oligohydramnios and IUGR is increased a lot. We don't know the reason. Every third patient in my ward is having oligohydramnios or IUGR. They are admitted to do after post-COVID. So again, if she is oligohydramnios or she is having IUGR or other problems, definitely chances of cesarean will be there. We're not going for normal vaginal delivery in the cesarean hall because we know there will be fetal distress and why to suffer the baby. So it is unavoidable things are there for increase in the cesarean section. So we can't say that it is increased due to the doctor or due to request by the patient. So we have to take these things into the consideration.
Another thing,
Yeah.
we shouldn't medicalize the things. So if we wait for the spontaneous onset of labor, if everything is going fine, even if patient comes at middle of night, we shouldn't crib at that time, because of our convenience also we ask them for induction of labor. So induction also, there are chances that may be successful or not successful as compared to the spontaneous labor. In spontaneous onset of labor as well as the progression of labor, the outcome is otherwise good. So that also helps in creating and maintaining the patient and her attendant's faith. If we don't give her oxytocin augmentation for induction, or even for, if we don't give them labor analgesia, means if we have given them even injection drotaverine or any injection is given, they say आपने दर्दें ठंडी कर दी. That is why the patient is landing up in cesarean. So in our practice we find that kind of things also. So if we keep the things natural, we tell them to roam about and do this kind of exercise, patients and her attendants acceptance is there, so that helps build up the bond. Because this doctor is doing delivery as our dai used to do, but in a supervised manner, because in their mind it is that the doula care is better than the doctor's care. If we come to a doctor, if we get admitted at a hospital, there are chances we will get cesarean. So that kind of mindset we have to change, and we have to encourage them that you will do well. So encouragement and patient support, that is very, very important.
Yeah, exactly. So we have a lot of long-term maternal risks also in cases of multiple cesareans. The placentas that we, the Akrita syndrome, that is the new thing that we are all facing. Dr. Neetu, how would you handle these cases of placenta Akrita, placenta previas also in cases of previous cesarean and the placenta Akrita syndrome? uh, I mean, how does that impact the patient and the surgeon?
Yes, yes, ma'am. In patient who had previous cesarean, now she's placenta previa. We are suspecting placenta previa or ultrasound is showing placenta previa. First of all, we should take a detailed history. Previous ops history should be detailed. Detailed history should be taken, whether it is previous one cesarean, two cesarean, three or four, because the patient who have placenta previous in this index pregnancy and had previous 1 CS or 2 CS, the rate of accreta increased rapidly. With previous 1 cesarean, it is 11%, 2 cesarean, it is 40, with 3 cesarean, it is 60, and with previous 4 cesarean, it goes up to 67%. So we should keep her ourselves ready for the peripartum hysterectomy, and also explain the patient about the risk of peripartum hysterectomy and risk of morbidity, more need of hospital, say multiple blood transfusions, need for ICU admissions, and other interventions also, ma'am. So during the antenatal period, we should do the Doppler scanning. We should grading of the placenta, whether it is increta, accreta, or percreta, so that we can counsel the patient. And our management should be multidisciplinary management, because these patient might bleed at any time. We should keep blood within hand. We also counsel the patient and her attendant about the need for multiple transfusion. 2 or 3 donors should be arranged at any time, ma'am. And HB of these patients should be repeated every 15 days, according to me. And secondly, we should keep in touch with the radiologist, neonatologist, and the one of the urologist. So that if the patient may land in the emergency with bleeding, we can contact them.
Yeah. Dr. Savitas, you are a very chiseled obstetrician. You are such a senior, you are the unit head. So, what is the frequency of these past cases that you encounter, and how many, every time does the senior person goes, or what multidisciplinary, you being in a Apex hospital, how do you manage such cases of placenta accreta syndrome?
Actually, I want to say any patient who is previous cesarean section with low-lying placenta should be managed as a placenta accreta spectrum, even if the ultrasound or MRI is saying it is ruled out. So all these patients from the beginning, once they are diagnosed with low-lying placenta, should be referred to tertiary care center. They should not be managed at a standalone practitioner, because multidisciplinary team is always required. Apart from the multidisciplinary team, we need a senior obstetricians, senior pediatricians, senior anesthetist, and preferably we should manage in a such a way that we are going for the elective surgery in these patients. So always elective cesarean, unless in the middle, if you land up in the middle of the night, these patients start bleeding at that time. Sometimes it's very difficult to get the uro guy, because we need the urologist as well. Because I've seen the bladder involved so many times. And now, as I told, the oligohydramnios is increasing. Similarly, the pass is increasing. I think every month we're getting 4 or 5 cases in our hospital of the full proved pass, and we might be landing up with 2 cesarean hysterectomies every month, I think, for this placenta accreta spectrum. And lots of blood are required sometimes. And hysterectomy, we have to take prior consent, even if she's not having any live baby. Sometimes she previous cesarean, but no live baby there. In that case, also we have to take the consent of the hysterectomy. And always we go for the, if it is placenta accreta, we go for the classical cesarean, because we know we can't give the incision in the lower segment. And classical cesarean is to be done, followed by non-touch technique. No touch, placenta should not be touched at all. If we start touching the placenta, start pouring, we will know where if she will start bleeding. And then once deliver the baby by classical cesarean, just clamp, take care of the upper uterine this incision, put the hemostatic there, and then go for the hysterectomy. Step by step hysterectomy is to be proper devascularization, and don't be in a hurry, because you're not touching the placenta, you're taking care of the uterine incision, and slowly go for that. If bladder invasion is there, call the urologist. Prior hand, they have to be informed in every case that there may be need. It is not that at that time you start searching for the urologist. So they should be informed prior hand. But we have seen so many times the bladder is involved, and we have to do the partial cystectomy also in few of the patient. Because there is no difference in the lower segment is almost gone. It is already taken care by the involved by the placenta, and the posterior wall of bladder is involved. So these things are to be taken into account, and at least 3 blood should be arranged. Along with that, not only the RBC, we have to raise for the FFPs, PRPs, because again the multiple transient protocol starts in these patients. So FFP and PRP should also be arranged prior.
So, do you think these cases where we have already antenatally diagnosed placenta accreta syndrome, should they be dealt only by apex centers? That is, I think, that
Yes,
should be
yes.
the message
But they should be
should they
referred,
come here?
once they are, yeah, once they are diagnosed, they should be referred to tertiary care where multidisciplinary approach is there. The good blood bank
Yeah.
is there, ICU is there, NICU is there. Because in these patients, we do the preterm delivery also. We're not waiting till 38 weeks to deliver. If it is approved, we know that the MRI shows bladder invasion is there. I've seen the two patients who came with the hemorrhage, hemorrhagic urine, hematuria. So we had to deliver the patient 34 weeks, and it was bladder was involved. Two patients I dealt with the hematuria, because if hematuria is there and the MRI says that bladder is involved, we have to deliver the baby sometimes even at 34 weeks. Otherwise, it will keep on invading the bladder and more problem will be there. So we have to do the corticosteroids for baby maturing and go for the early cesarean.
I think this is very for everybody. One should be very, very. I mean, one should not take it on your ego. Keep placenta accreta. Once you are caught unaware and you open, even and when you encounter unattended that it is a placenta accreta syndrome, you may just close the abdomen and send the patient if you are not equipped enough uh, to handle placenta accreta. If you don't have that multidisciplinary team, you don't have a urosurgeon, you don't have a blood bank, or you don't have the another senior assistant or a surgeon or a senior staff in your to help you at that particular time, you should not be touching such cases, and you should at least send them to a higher center where at least the patient, the morbidity and mortality that you are preventing is much will pay you much better than sort of tackling that case in a center without much help. So that is a very important message one should always carry. And these days, with the increasing number of cesareans, the incidence of placenta accreta is increasing per Creta, and in Creta per Creta is increasing. And the conservative approach is is only in very few cases that we can go about. Now, another thing that I wanted to ask was about the role of medico-legal pressure that is there in the rising trend of cesareans. So, I mean, sometimes in our private practice, we feel that normal delivery maybe we may not, we may in second stage of labor there could be a rest in, and then we do a cesarean, then we are again caught, and it would be a very difficult cesarean. So sometimes in I mean there are issues where we are a little scared about the medico legal pressures. Does that also increase, is somewhere responsible for this increase in cesarean sections?
Yes, definitely. I will say there is increase, especially not in the normal patient, young age patient, first pregnancy, and she's not having uncomplicated pregnancy. Usually, there is not the problem. But if she is high risk pregnancy and the patient lands up with prolonged labor, so, and we say we can wait in the prolonged way for 4 hours, but due to that medical legal pressure that you don't know, even if you're using CTG and everything, fetal heart is okay. Sometimes, definitely in these patients, if fetal distress is there, you will land up with the early cesarean section. So, some pressure is there, especially for the high risk pregnancy, especially if the prolonged labor is there, fetal distress is there, and the known progress of labor is there, the cervix not dilating. And though we say we can wait for 3 hours, but they may take the decision after 2 hours. Head is not descending, and you're sometimes we may for 3 to 4 hours, but after 1 hour they will go for cesarean. So little bit of pressure, I think it is always there for the care of the baby, not for maternal, it's for baby's sake. Because everybody wants to have a safe, normal baby, no distress, because it's so much a problem. Already, there's some are planning only for one issue, some are planning for two issues. As Dr. Bharti has explained, someday birth asphyxia is there. It is a lifelong problem for the parents and the baby. So the birth asphyxia, everybody wants to avoid. And if prolonged labor, non-progress, fetal distress, in these cases, there's a medical legal pressure is always there to have early cesarean.
Dr. Savita, you just mentioned three things just now: non progress, fetal distress. So, these are the two actually the indications which make the bulk of cesareans. It is the non progress. We So these days, should we again go with our old theories, or nowadays the new set of definitions have come? So anybody would like to highlight when is the latent phase? How long can we wait for the latent? When do we call the patient is in active labor? When we call it is a protracted labor, or when there is a arrest of labor? So have the definitions nowadays a little bit changed? The duration of second stage, has it changed in primies and in multis? So we would like to have a little bit of a detailed discussion on that. Anybody would like to state when do you exactly call the patient to be in active labor, at 3 centimeter, 4 centimeter, or at 6 centimeter?
6 centimeters. All
6
the
centimeter.
definition have changed in the recent times
Yes,
actually. So
yes.
6 centimeter is being taken as a active labor. So before
Right.
6 centimeter, patient might be anything which say it is in, not in the active labor. And then the second stage, prolonged, all are increased by 1 to 2 hours. Previously used to
Yes.
say 2 hours. Now it is 3 to 4 hours. That's why I'm saying that we are not ready to wait for 3 to 4 hours. Though the recent definitions are longer one. So these things are for the high risk pregnancy. I'm saying. If patient is uncomplicated pregnancy, young patient, then definitely we can wait for the 3 to 4 hours. But most of the patient in present era are not the means they're not young patient. The young patient is they are uncomplicated. They mostly deliver so fast. They very less chances are there that you are waiting for the so many hours for the second stage, and they deliver so fast. Only in the complicated pregnancy these problems arise, and only in those cases there is some medical legal pressure is there that you go for the
Also,
early. And I
we do a
think
lot of NSTs, these NS or the CSTs that
CTG,
we are doing.
CTG, not NST,
The
CTG. Yeah.
CTG. Right.
So it
So
should
the
be there.
CTG,
It should be there. Yeah.
the CTG that we do, and we find a little non-reassuring fetal heart rate, and we jump to cesarean. So a little bit of late deceleration, and we think that okay, let's go in for a cesarean. So that also maybe is
Should be not
increasing
be
our
there.
cesareans. And I mean, we have to read our CTGs with a lot of maybe a pinch of salt, and we have to be very, I mean, crucial that it is a crucial factor in deciding actually sometimes whether we can wait for longer with those decelerations. Sometimes maybe there might be just cord compression and we are getting a variable deceleration, and we
Actually,
feel that okay.
every case has to be individualized for these things. We cannot say we cannot follow all the guidelines of 4 hours wait for the second stage and to label as a prolonged stage. So every case has to be individualized for this. So high risk pregnancy, I am feared that everybody is feared if high risk pregnancy is there, we can go for the early. And if late decelerations are there, or if late are not a little worried about late, but variable decelerations are there, just change the posture of the patient, keep in the left lateral, hydrate the patient, and give the oxygen. And she's already 6 7 centimeter. So most likely she will deliver in next 1 to 2 hours with good. So in that case, we can wait. It is not that one or like Dr. Jyoti is asking. With little deceleration there, immediately we should not go for the cesarean. Definitely, we should give that trial and this. So individualization of cases there.
Very
This is
important.
shared decision making. We have to
Yeah.
involve the attendants also. At times, the attendants blame that you
Every
had
step.
so much
Every
window.
step.
Yeah, we have to involve them in every step. Even if we are augmenting the labor, even if we are giving them pain relief, or if we are doing CTG, so we have to inform them that these are the latest findings.
It is better to
Yeah.
keep the record of the CTG with you because
Yes.
for the medical legal you can have the problems. So that's why the CTG is must in these cases. Keep the record so that you can show the and keep your labor record. Proper labor record is to be kept.
Partogram is something which is very important, and do we all follow that, and how does it help in standardizing or our mode of treatment?
So
Do
A
you
very
do
good
you
particularly,
think it is?
this is an objective thing. So that is for doctors, staff nurses, as well as for the attendants also. So that gives us confidence, and to the patient's confidence that it's really patient is not progressing. Because if we tell them these are the PV findings, head is not descending, or cervical dilatation is not improving, this is the action line, alert line, as we used to have it earlier. So that is, in those cases, it's easy to counsel and tell them the patients that they should go for cesarean, or they can wait for the vaginal delivery. So that is a very good
Yeah.
tool.
Basically, nowadays we are following the labor care guide.
Yeah, labor
So in
care
labor
chart, there
care
is
guide is a
similar
recent
things
one
are
in
there.
which respectful maternity care, analgesia is also taken care. And partogram is one of the part of the labor care guide.
Component of
Especially
that.
in the where multiple shifts are there, big hospitals. Partogram is very good because one shift is changing second, so we are having the written records. If single obstetrician is there, they may be following the patient throughout. In multiple shifts, staff nurses they can see how much dilatation at which time was there, so that they can follow the. So it's very very good to have the partogram. It is very good. And labor care guide is additionally respectful maternity. Dr. Bharti Dola means one attendant is to be kept with the patient who can do the counseling, who can do the back rubbing, psychological support, give fluids to the patient. Whatever help little psychological support will be more with the attendant. So respectful maternity care is also part. And analgesia. Give proper analgesia to the patient if she's having excessive pains, hydration is to be taken care. So these are the things. If you add on these things, respect to the definitely the labor is going to be smoother for that patient as she may deliver fast.
Right. I think now the last and maybe one or two questions about TOLEC. So, Dr. Neetu, what is TOLEC and which how do we practice? I mean, which party do we once a cesarean, always a cesarean? Does that should we follow that or it is not like that? We what are the chances? Which particular cases should be taken for TOLEC? What are the prerequisites? And you please throw a light on that.
Yeah, ma'am. Ma'am, actually, I want to explorate the toilet trial of labor after repeat cesarean, and this is very important in current scenario to decrease the rate of cesarean section in all patients who had previous cesarean. Previous one cesarean, specifically, I am stressing previous one cesarean. Before making the decision for trial of labor in patient who have repeat previous one cesarean, so we should make the plan of her further delivery or TOLEC during antenatal period when the patient was not in labor, reviewing the previous obs history, keeping the maternal age, her high risk, her obstetric, her comorbidity, indication of previous cesarean, whether it was elective due to abnormal presentation, done during labor, and birth of previous baby, and in index pregnancy, her current indications, any comorbidity, diabetes, hypertension, any other high risk factor. So we should do a scoring near around 36 week with written informed consent, discussing thoroughly with the patient, and we should all mention all these on the ANC paper of the patient, keeping her BMI, age, BP, all are should be mentioned. If her score came more than 8 out of 10, baby weight is appropriate less than 35 week. Her BP records normal. Previous cesarean whether done due to abnormal presentation, and then now she is her fetal no, there is no indication for repeat cesarean if any of the indication is not. So we can counsel the patient for trial of labor, explaining about the benefit of the women that she has 70% chances of vaginal birth, repeat vaginal birth, out of 100. 30% she might land in the repeat cesarean. And we should also explain the patient about the need of the further cesarean if any there indication is there.
Right. So, I mean, do we try it in our smaller setups, or do we always have a blood ready in case of scar rupture or anything, or what other prerequisites should we have when we think of TOLEC? Is it
Yes, ma'am.
what is the percentage of patients that normally deliver vaginally after our trial? What and which
Uh,
definitely should be taken up for a repeat elective cesarean only?
Yes, ma'am, definitely. We should always do the hemogram of the patient. If patient was clinically anemic, we should hemodynamically build up the patient and keep blood ready in the blood bank. And we should also explain the patient that I am repeating again. She had 50%, 70% chances of a vaginal delivery, successful vaginal delivery. 30% she might land in the next cesarean, ma'am. So, out of
Right.
700, I think 70 is a big figure, ma'am.
Okay. Dr.
The
Bharti,
selection
what
of
is
patient
your
is very important.
very
Yeah, ma'am.
Selection of
important?
patient is
Yes.
very important for TOLEC. That is a very
Hmm.
important thing. And once you take the informed written consent is to be taken, every patient has to be told about the risk of the scar disease. You don't know, even if you selected the
Yeah.
patient well, still risk of scar descent is there, and the continuous observation should be there regarding the early signs of scar descent like dysuria, hematuria, this non-progressive labor, slight fetal distress, tenderness. So that is to be taken care. And usually we go for toilet for the spontaneous labor. Induction of labor in patient previous is a little difficult. So we're not using these drugs. We cannot use a misoprostol for induction.
Yes.
Only one thing which can be used for induction is a Foley's catheter. This mechanical method can be used. Otherwise, it is better the patient who goes into spontaneous labor and they're better selected patients, means no recurrent indication is there. If recurrent indication, always go for the elective cesarean. So then only in these patients, high chances of vaginal delivery are there, like Dr. Neetu has told. But the proper informed consent is always to be taken, and facility for cesarean and blood should be there where you go for the toilet.
Right. So finally, I think another 1 or 2 minutes, since we are close to 1 hour discussing this. So, what are the absolute indications where we need to do a cesarean? Maternal, fetal. What exact are the? I mean, fetal. Maybe 1 or 2. One can enumerate where we will not even think of a normal delivery.
So absolute
Yeah.
matter. So you continue.
No, ma'am. You
Please
can.
you continue.
Okay, ma'am. Ma'am, absolute maternal indication include abnormal presentations like breech, transverse lie, oblique lie. Even in primary breech, we do not have a current any complications. We can trial for the external version, ma'am. But and abnormal placentations, ma'am, and active herpes infection in third trimester of the pregnancy, ma'am.
Absolutely.
Contracted
So
Henry's.
some infections like herpes infection and active HIV or what all other infection, maternal infections that can tell, I mean, definitely there we need to go in for a cesarean section, and also certain maybe cervical growth, cervical fibroids,
Yes,
any
always.
Yes.
pelvis, if there's any problem with the outlets. So these are the absolute indications. And regarding the fetal indication, the malpresentations, severe IUGRs, or maybe
Joint
twins.
twins.
Yeah, yeah.
Conjoined twins.
I wanted to discuss twins
Malformation.
now. Yeah, what in twins, if it is a first cephalic presentation, what we should be trying a vaginal delivery rather than going in for a cesarean. And but if both are non-cephalic, so if the presenting one is a breech, then I think that would be an indication for a cesarean. But first cephalic twin pregnancy should always be tried as a for vaginal delivery. So these are the I mean those are the various indications: placenta previa, placenta accretas. So those are the absolute indications where we should be doing, we have to do cesareans. And the other these are the, I think this is the only way where we know that these are the absolute indications, these are the relative indications, and these definitely we should be just going in for a vaginal delivery, and specifically in cases of a primary, so that we can reduce our subsequent cesarean rates and the morbidity and the mortality associated with the cesarean. So I think that was a wonderful, wonderful discussion that we had today. And overall, when we see the vaginal delivery versus a cesarean, the morbidity and the mortality, in case of vaginal, it is around 8.6 versus 9.2. But mortality in case of a cesarean is around 2.7% compared to 0.9%. And mortality in vaginal is 3.6 per 100,000, whereas in cesarean it is 13.3. Amniotic fluid embolism again are 15.8 out of compared to 3.3 in cases of vaginal deliveries. And such, so there, I mean, these are the cases. I mean, if we are trying a cesarean and if we have such a problem, then definitely we always should be thinking more in favor of a vaginal delivery, though the risks of these perennial lacerations and maybe some urinary incontinence, which later on is as good as a cesarean. So immediately, maybe sometimes we should start right from the antenatal period, talking, preparing these young girls, the primaries actually. So first vaginal delivery, and second, though we are in multis, we are very good that okay, she would deliver vaginally, but primaries are the ones that we need to focus on, so that we can reduce our cesareans. And nowadays the audit also is there. So definitely we do have to also send our reports, what is the vaginal delivery rate versus our cesarean deliveries. So even our government bodies are really concerned, and that is the way we can reduce the cesareans, by auditing, by doing a internal audit as well as external audits, so as for this. So
I,
any one comment from our panelists, and then we can close the
yes,
discussion.
I want
Yes,
to share that
yes.
our society's role in reducing cesarean. So our society plays very important role. So we that we can label as primordial prevention of cesareans. If we take care of nutrition of girls, young girls when they become adult, before that, so their diets should be sufficient and they should be supplemented with the calcium and vitamin D. They should involve the physical activities that we don't see in our girls. Physical activity involving the proximal muscles, abdominal muscles, as well as the pelvic floor muscles. And the third one is about the yoga meditation. And during pregnancy, they should know the stress management, because nowadays, because of this advancement in technology, just sitting and watching either computer or mobile, whatever they want to say, their physical activity has reduced, stress levels have increased, and fear of pain, the pain tolerance, that is very much decreased. So society must play role in controlling all these parameters. If a healthy girl becomes a lady and conceives her pregnancy, there are chances that she will be a healthy mother and deliver vaginally. And with this stress management, the yoga and meditation and spirituality, which is lacking, because if we have positive faith, if we have positive feeling that we will deliver and we will have very good outcome, the things will show very good results. And we should never forget, during pregnancy the antenatal classes play a very very important role, because that is the time when everyone is perceiving whatever you information impart to them. They are very receptive when they think of their baby. So from our part as clinicians and from the society, we will expect that thing. If they have able to manage, the outcome will be very good, and in future we will see the reduced cesarean section rate because of our good generation. So madam will conclude with this.
Yeah,
That was my take on this topic.
right. Yeah, Dr. Neetu, one final comment from your side, how we can help in reducing, and then we take the final comments from Dr. Savita.
Yes, ma'am. For this, we should take a foster environment should be there between the patient and the treating obstetrician, so that patient may be comfortable with us and she can freely talk to and communicate with us. And we should always make a written informed consent about the birth preference of the patient, about the vaginal delivery, cesarean delivery, explaining the about risk and benefit of both of them.
Right. Dr. Savita,
Ma'am,
and
Yes, we
yes,
should avoid the cesarean on demand, especially by the extensive counseling of the patient, her family, and her relatives. So that is extensive counseling is to be done towards cesarean on demand. Secondly, we should go for the external cephalic version, especially in primi or in multi with the breech. We can go at 36 to 37 weeks to have positive outcome. Then antenatal exercises, these Garb Sanskar, some videos are coming. They can have this positive attitude, antenatal exercises, and then less fear in the mind of the obstetrician as well as the patient. That is by the counseling. The obstetrician also needs counseling, I think, to have less fear that what will happen, prolonged labor is there. Definitely, 99% of the patient deliver in a good manner if she is fit for the general delivery. So these things, positive attitude is very important. Antenatal exercises, counseling, and follow the guidelines. We have to follow the guidelines. Though the latest definition is to come for the prolonged labor, and this these has to be followed in most of the patient, and then we can avoid. Definitely, we can avoid the high rate of the cesarean section by this.
right. So, thank you so much, our panelists. I think we had a wonderful discussion on are we cutting too deep in the maternal health, and I think we all are not. We are all trying to go in, promote as much a normal delivery as we can, but definitely there are indications where cesarean is needed, and that is how I mean, why that is why we have multiple modes of delivery, and cesarean is one of them. And at the end of the day, we also have to think of a healthy baby as well as a healthy mother, and even with the lots of good anesthesia coming, and the morbidity with cesarean also is very very low. So not all cesarean is not that bad as well, but definitely we have to think wisely. We have to go with the guidelines, and we have to select our patients carefully and be in constant sort of repo and touch, and make a confidence with them if with every visit that they come to. So thank you everybody for your time and for your discussion. And I'm sure, do we have any questions, Srihan? Do we have any questions in the chat box?
No, ma'am, nothing as such.
Oh, okay. So we have already discussed each and everything. So I think this, Shriya, now over to you, and thank you IJCP for the opportunity. And this being the International Cesarean Awareness Week, we loved doing such an activity with you. Thank you on behalf of our panelists as well.
Thank you, ma'am.
Thank you.
With a warm thanks, I would like to thank all of you for joining us today, and also our viewers. And it's a pleasure to have you in our platform, ma'am. Thank you so much.
Thank you.
thank you.